Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome back to The Starting Gate. We're your hosts, Dr. Kitty Dotson
and Dr. Sarah Sheets.
So hopefully this month has been helpful for you so far. We've talked about some really common musculoskeletal pains, including osteoarthritis of the knees and chronic back pain. And today we're going to continue to talk about some common musculoskeletal pains and actually an approach that I don't know much about myself, which is the role of osteopathic manipulative treatment for treating some of these common conditions.
We also want to touch a little bit on this specific type of medical practice as well with our guest, because she has opened up a direct primary care practice here in Lexington, and I know that's something that many people are not familiar with. We have a lot to cover, so we want to get started. First, I want to introduce our guest, Dr. Selena Raines. She is a board-certified family medicine physician here in Lexington, Kentucky, and has opened Body, Mind, Spirit Direct Primary Care out in the Hamburg area here in Lexington. Can you let our listeners know a little bit about you?
Yeah, thanks, and I appreciate you guys having me here today. I went to medical school in Pikeville at the osteopathic school down there. I did my family medicine residency training in Moorhead, Kentucky, and I stayed on there and worked clinically there for 5 or 6 years, and I was a faculty member for the family medicine residency program there. During that time, I guess it was during residency, I had first learned what direct primary care was and just filed that information away. And as I was working in the system, it had nothing to do with my specific employer, but just the system of how we do healthcare in general in this country. It felt very depersonalized and rushed. I really wasn't able to do the best that I knew I could do and what I really set out to do when I became a physician in that type of model. I finally made the leap and opened up a direct primary care practice where I can provide people with personalized primary care in a meaningful way, in a convenient way, and in an affordable way.
I researched this practice model a whole lot myself when I was leaving my previous job and learned a lot about it, and I love it. I love how direct primary care works. I think it's an answer to many things that people are looking for and aren't able to receive in traditional healthcare model. Can you explain to our listeners how a direct primary care practice works and how it may be different than something that they're more familiar with is a concierge model? I know that terminology a lot of people have heard, but just distinguish the difference between those two as well.
Absolutely. Direct primary care is definitely something that is growing across the country in popularity and as a practice model. If you go back to, as a kid, you're watching TV and you think about that small town family doctor and all the things that they did in that capacity, then I think that's what direct primary care is. It's a physician who is available and knows about you, knows about your family, and has a lot of different aspects that they can do, a lot of different things that they and services that they can provide as a family physician. Direct primary care in general it's a membership model, which is something that's different, and to not detract from the importance of healthcare, but it's essentially like Netflix for healthcare. You pay a monthly fee, and you can watch as little or as much as you want. It's the same with healthcare. The purpose of that is to be able to have access to your physician. You know, what I tell my patients, you can call me, you can text me, you can email me. I have a patient portal that they can use to send secure HIPAA-compliant messages. And when you call, you're going to get me on the other end of the phone. Obviously, if I'm with a patient, you're going to get the voicemail, but it's just me that runs the practice. You're not going through a phone menu and things like that, which is often very frustrating when you're trying to
No
call
call center, you're telling me.
Exactly. There's no call
call
center. And that's the big part of it. The other thing is there's no rushed visits. I know myself, I've been to a physician's office and you go in, you sit in the waiting room, you're waiting for your turn, then you're waiting in the room, and then you get about 5 minutes with the physician. I mean, you guys worked in these models as well. They keep your schedule so full and so busy that you feel like you've got to rush to get to the next person. And so I didn't want to do that anymore. So direct primary care is the way that you can get around that. And for patients, it's nice. If we need to take an hour to talk through things, we have an hour to talk through things. If you just need a quick stop in, you can do that as well. If we can handle it over the phone or texting, a lot of people prefer that too. It's just nice to know that you're going to get an answer very quickly on the other end of the line.
So in this model, someone would be paying a monthly fee.
Correct.
And then when they come in to see you for their, let's say, their routine hypertension visit, is there an additional fee with that?
There is not in this model. And that's the difference in concierge and direct primary care. Concierge, you really are paying an access fee to be a member of the practice, but then typically those practices will still bill your insurance. So you still need to have insurance. You're going to have a copay if that's the way your insurance is set up, if you've got deductibles to meet, all of those things. That's the difference really in concierge and direct primary care. In my clinic, all these visits are included. There's not an extra fee unless there's something like we talked about, and we're going to get into a little bit more, osteopathic manipulative treatment. But otherwise, there's not additional fee for these visits. And if there is any, which we'll talk about medicines and labs and things like that, if there is going to be any additional costs, the patients know up front. We talk through that. And sometimes we even decide what's going to be our next best approach depending on we're going through a differential diagnosis, and we are trying to see how to best utilize the resources that they have and the cost sharing for healthcare.
So just for somebody thinking about this, might be paying this fee for themselves or their family every month. And some months they may not need to see you or message you or anything during those months, but they're still just maintaining their position in the practice. And then some months they might come see you for a routine visit. Then they might get sick, need to see you again. Then you might have to have them follow up again. So they might see you 3 times in that month, but that's still
the same
it's all included. Fee.
Mm-hmm.
Okay.
It is. Yeah. And the other beauty about direct primary care versus kind of the traditional model, if you look at the data, most employed physicians, primary care, family medicine, you can say they're probably going to have you assigned 2,200 to 2,500 patients as your patient panel. As direct primary care, I'm going to have 400, 500. Every person is different in how they set up theirs, but you're not going to have to compete for my time and access into the clinic with 2,500 people. It's going to be several hundred.
And you really get to know each of those patients very well.
I always found people were really surprised by that when I'd say the average primary care doctor has around 2,000 patients. Most people are shocked that it's that many. I think people just assume that you have 500 patients or so, but really that's why concierge medicine and direct primary care have been expanding, because having those smaller numbers just lets the provider have a closer relationship and be able to see you more easily.
And that's why it makes it so hard in the traditional model to get to your primary care doctor within a week's time, even if you have something pop up, because they have so many patients that they are having to see that it's really hard to see them when you have an acute complaint come up. It makes it challenging. And some practices never even close panels. So some primary care doctors just have this continuous influx of new patients forever. And that's really challenging to get to know patients very well that way.
Even when they want to, they probably
they want to.
You call and they want to see you. They really do. It's just that there's no space in their schedule.
There's not enough time in the day. And I know on a previous show we mentioned they've literally studied primary care doctors, and for them to do all that they're supposed to do with this large of a panel size, they would never sleep. They could never sleep in order to give all the care that they really should be doing. I love this about the direct primary care model. And the other one you already alluded to a little bit, and this one blew my mind when I started to learn about direct primary care, is the cost savings of lab work as well as medicines that direct primary care practice can have for patients. Can you expand on that a little bit more?
When researching this and learning about this, even as a resident, you hear about, oh, there's cost savings. You're like, oh, that's great. But when you really get into the nitty gritty of it, it's almost upsetting when you see
It made me
how
upset.
much.
It made me upset.
It's almost, it really is. When I think about seeing a typical adult patient, routine labs, just checking either once a year or if they've got some chronic stuff, a couple times a year, we would do a CBC, you would check a chemistry to check their electrolytes, their kidney function, liver function. I would do a lipid panel, a TSH, and a hemoglobin A1C for a lot of people. That panel of labs in my clinic is less than $10.
Wow.
It's less than $10.
I'm going to go ahead and put the wow. Because at a large healthcare facility type place, that amount of labs would be $200 to $300.
Absolutely.
I would bet, depending on how much you may not pay all of that. But there also can be a facility fee.
There can be.
There too, which can make that cost even more, especially if you have a high deductible plan. Mm-hmm. That round of labs could be costing you $300.
Absolutely. You'll pay every bit of that if you have a high deductible plan. So yeah, that is getting into that aspect. It's wow, knowing what I've paid for labs before.
Yes. So actually, before we talk about medicines, the same is for imaging, because that is another one that in Lexington, there are local options that are not in a big center that have more affordable imaging options for cash prices that, again, I was unaware of.
Yeah. MRIs for $350.
Yeah,
It's
totally.
unheard of in the system to pay that little amount of money. Specifically, I remember I had to have a CT scan myself, an abdominal CT scan, when I was working for my employed physician job. And what insurance had negotiated the price down, I had a high deductible plan. I paid $900 for that CT scan. And you can get that for about $500 at the local imaging centers.
Without it going through insurance at all.
Without it going through insurance. There was no pre-certification. There's none of that. Yeah, it is insane how affordably we can do healthcare.
And another option is that you also are able to, not a full pharmacy, but you have medicines that you're able to have patients buy at the practice as well for cheaper prices.
Correct. Yeah, the state of Kentucky does allow physicians to dispense medicines from their office. It's just generic medications. Most generic medications I can dispense for $2 or $3 a month at the most. Some of them are $3 for a 90-day, 100-day supply of medicines. A lot of the common blood pressure medicines, cholesterol medications, some of the older medications for diabetes and blood sugar. There's a whole host of things. A lot of the mental health medications, antidepressants and anti-anxiety medications as well, are very cheap. I have several patients who have insurance and still come get medicines from me because it's cheaper than their copay at the pharmacy.
I think especially if you don't know much about this world, and you two know more about it than I do, it's really hard to wrap your head around it sometimes.
It sounds too good to be true.
Yeah.
And that's what a lot of people say. They're like, but it can't be that easy. They're waiting for the other shoe to fall. And it's, no, that's it.
And I think the reason that it works is because when you have a practice, your practice is only supporting you because you're
Correct.
the only employee there, versus when you have to think about the size of medical practices in other situations, as well as buying things from pharmacies. There's just so many people that these businesses are supporting, and it requires them to run it, that you're able to just provide such affordable care when we go back to the basics and have medicine like it used to be.
Absolutely. Taking out all of that extraneous things that, like you said, the billers and coders. I think the last data I saw was about 25% of healthcare expenditure goes to trying to get paid from insurance companies. And I'm like, that just sounds crazy. Like, we're spending that much money just to get paid. It's
Overcomplicated something that should not have been this complicated.
Majorly overcomplicated it.
And do you mind just saying, because I think people might be listening and wondering, I can't afford to pay $500 a month to be a part of your clinic, but it's actually not that much. Can you, you don't have to give exact, but tell people like how much it is?
Mine is age-based, which is what a lot of direct primary care practices across the country do. When you look at the basis of direct primary care, if you had to define it, a lot of practices would say it's less than $150 a month as a membership fee. My typical adult, someone my age, it's $89 a month.
So that's just probably less than what some people are thinking that it would be.
Absolutely.
So.
Especially when you think about if you do need to go to the doctor regularly, multiple times throughout the year, what co-pays can even be.
Right.
It sometimes is similar.
Right.
If
A
you,
copay and
if
then
you
a
account for the
deductible
cost of labs, copay, and then you're getting that added benefit of always getting your doctor and being able to communicate with your doctor, it ends up being a wash depending on what type of insurance you have.
So speaking of that, direct primary care does not do any insurance billing, right?
Correct. I don't bill any insurance. Certainly, I have patients who do have insurance, and they will use that sometimes if they want to get imaging done and use their insurance to cover it. If they want to have labs done and use their insurance to cover it. If they need to see a specialist, if they need a hospitalization, something like that comes up, then they have insurance. And honestly, the ideal way for direct primary care to work is you have a very high deductible, catastrophic, low-cost insurance plan that would cover things like, God forbid, you need a surgery or you had to go to the ER and needed hospitalization. That would cover it, but you're not paying for all the bells and whistles of healthcare. Your direct primary care physician can handle about 90% of most people's healthcare needs and not have to go to have this premium insurance plan that you don't use a lot of.
Because the high deductible plans still cover things like a mammogram,
They
or
do.
colonoscopy, and that kind of thing. So that really
Absolutely.
would be the ideal pairing for someone would
Right.
be if they had a high deductible plan and then using a direct primary care practice with that.
Yeah.
But even if you don't have insurance,
Correct.
not something I would recommend. And I just want to put that out there. I think you never know when things are going to happen to you. A long hospitalization could put you in the hole for a really long time. So definitely don't encourage not having insurance. But if you don't, this would still be a good option for you.
There's a growing number of people out there that fit in that hole of they don't qualify for Medicaid or Medicare, and their employer does not provide insurance, or it's unaffordable, for them to buy something on the marketplace, which is often, if you have a family, the average cost is $24,000 a year for coverage for a family. And so if you don't have $2,000 a month and you don't have an employer that's helping to cover that, it's just not affordable. It's a way to get some access to care. And a lot of times there's some of these stuff that can be prevented with routine care if we kind of stay on top of things to prevent that ER visit or that exacerbation that happens and you're at the hospital.
Seeing you or seeing a direct primary care provider, that doesn't keep you from still going and seeing a specialist or having other doctors that are in a bigger system, right?
Correct. No, we can make referrals for the specialists if you need to go see a specialist.
Now, for direct primary care practices, are patients able to use HSA funds to help cover the cost of their labs or their membership fee or their medicines?
Yeah, this is something that has come up multiple times over the years. Different states and then the federal government themselves define DPC as a non-insurance model. And so this debate has come up multiple times. If you ask the experts in the DPC space, yes, you can. There is some legislation that's been floating around the past few congressional sessions federally that is trying to further define this and change some of the language in the IRS tax code to make sure that it is 100% able to be used. But I always tell patients, check with whoever the administrator is of your HSA or your tax preparer just to make sure that you're not doing anything that's going to get you a penalty.
Before we stop talking about the direct primary care model, I think it's great if you could explain to our listeners who is a great fit for a direct primary care doctor, who gets the most out of it.
Honestly, I think it does depend on each individual's health goals. Obviously, there's people who have significant medical needs and they have no other means of coverage. They can't get medications affordably. They can't see a physician affordably. That's probably the largest part of my population right now. And then there's people who do have insurance and they have great coverage, but they want a more personalized relationship and better access to their physician. So honestly, I really don't know that there's anybody who wouldn't benefit from this model, to be honest.
I think on a regular basis, physicians and patients both are just so frustrated by traditional models. it's just great that there's an option, because I've heard so many times, I just wish I could talk to my doctor. And that's what direct primary care solves. Like, you
Absolutely.
are able to talk to your doctor when you need them. You don't have to wait a month. You can talk to them the same day and be seen very quickly beyond that. And so it really helps to have that long-lasting relationship with a physician and actually be seen and not have 20 million middlemen in your care.
And I think there's a lot of people out there that also just have health anxiety and healthcare anxiety. And you think about it, they wait 3 months for an appointment, and then they know they've got 15 minutes and they've got a list, and they're worried, I got to get this all out now because I don't know when I'll talk to you again. And this model alleviates a lot of that. You can focus on one thing at a time and really get somebody back on track for their own healthcare goals, because we're not limited by time and the next appointment available and those type of things. And I've noticed that I've had some people who haven't been to a physician in a long time because of that healthcare anxiety, and we're slowly working through it, and we're getting them. You can see improvements in these patients from the first time I met them. So
That's amazing.
I know, Sarah, you were thinking about this from the lifestyle medicine standpoint, because it seems like these types of practices just allow you to incorporate those other modalities, like more education on nutrition, probably allowed you to incorporate more mental health attention. And I know for you in particular, it allows you to incorporate the osteopathic manipulation treatments that you have been trained into.
absolutely. I think the other thing too is it can cut down on the need for specialists, because you've got this knowledge and you're like, but I need to read on this a little bit more, so we do a good workup for you, because it doesn't always come right to the forefront of your brain if it's something that's not typical. This model allows you to stop, take a breather, go through that, get a workup, and then decide, do we even need to see a specialist, or have we solved the problem? And if nothing else, you get to the specialist with all of the right information and all of the right data to make that visit more meaningful, instead of them having to go to specialists over and over again. Because we know those appointments can take 6 months, a year sometimes, depending on the
That's true.
specialist that you need. So
I think that is a great point. Just being able to have the time of maybe working up something that we don't necessarily do on a daily basis, but just with a little bit more time, we can do it.
absolutely. Absolutely.
I know Kitty just mentioned this. We would love for you to tell our listeners, what is osteopathic medicine? Because I think that this is something that so many people don't understand. They don't understand the difference in training between a DO and an MD. And we really want our listeners to just understand what it is that you have different in training, as well as that many MDs and DOs go to the same residency programs in general. So it's just a little bit different of approach.
Absolutely. I think for the most part in healthcare, people don't know their doctor. They don't know if they're a physician. They don't know if they're not a physician. They don't know what credentials they have. And this has been something that you see across the board. So I think the first thing to let people know is that in this country, in every single state, there are only 2 types of licensed physicians, and those are MDs and DOs. And the thing is to understand is the training is largely similar. As an osteopathic physician, from the get-go, we learn a lot about the musculoskeletal system. We really take a deep dive into anatomy and physiology and the structure of things and how those affect the function of the body. We have tenets of osteopathic medicine, and the very first tenet is that the body is a whole and is a unit of body, mind, and spirit. And that is where I derived the practice name, because that's something that I believe wholeheartedly, that we have to incorporate all 3 of those aspects in to really meet the healthcare goals for a person. So medical school as a DO is the same as you guys are. It's a 4-year medical school. We had an extra class in medical school that was osteopathic manipulative training and osteopathic principles. And we did about 200 hours through the first 2 years of the didactic portion of training. And then much like you guys did, we went out for 2 years on clinical rotations, and we learned about all the different aspects of medicine. And then we have to pick a specialty. And so I picked family medicine, and we do residency, and I did residency alongside of MDs. But we continued our training in osteopathic medicine, and we did osteopathic manipulation during that time. Not every DO does OMT, and some people just it's not their thing. They're not into it. But a lot of people, I think, end up not doing OMT because the system is not set up to allow for that. It takes a little bit more time. And unfortunately, we are in an RVU-driven system it's volume-driven. You got to get patients in and get patients out. And it's not to say that's the right way to do things, but that is the model that is typically used in this country. And a lot of that does not align with being able to stop and take a few minutes to do osteopathic manipulation. I went to osteopathic school because I had met some DOs when I was in the Army and watched how they practiced medicine, and they were so excited about what they did. I saw them doing manipulations on people in the middle of the jungle in Bolivia, and I was just fascinated by it because I'd never heard about osteopathic medicine. I grew up in Louisville. My doctor was a doctor. I didn't know any more than that. But even in college, I never heard about osteopathic medicine until that point. And so once I decided that medicine was going to be my path, I sought out that training. And we do have an osteopathic medical school in Kentucky, and it's over in Pikeville. So from the get-go, I knew that I wanted to incorporate OMT. I wanted to continue to use that as part of my practice and treating patients. So I stayed an extra year of medical school, and I did a pre-doctoral fellowship in OMM and osteopathic manipulative medicine and anatomy. So I went back through anatomy lab as table trainer and through osteopathic training as well. So it was a way to start to teach those things. And I had patients of my own in our clinic that we had on campus. I worked with some residents and some world-renowned faculty members who are experts in the field of manipulation. I did take advantage of doing that. And it's just been a passion of mine to continue that forward.
Oh, that's neat. So can you tell us, where does that come in? Like, when is OMT helpful for somebody?
So again, when is it not? That's my answer to that. My brain has been taught to kind of always think about the structure and function and how those are interrelated. The big thing most people think about is aches and pains, right? I've got back pain, I've got joint pain, and those OMT is great for. What we're doing is we use our hands to assess the body. I'm looking for, again, function. I'm not so concerned about alignment because none of us are perfectly symmetrical and none of us are perfectly aligned. As long as all of our joints are functioning the way they were designed to, we have muscles that are not overworked and overused or muscles that are underutilized and not as strong as they should be. I like to look at the ligaments that hold one bone to another bone. You can get tension in those. And so the goal behind that is if we can improve the structure, then we're going to have overall better function of the body. We're going to have better blood flow, better nerve conduction, better lymphatic drainage, better ability to get oxygen and nutrients to all the different tissues. One of my favorite places to use OMT is in chronic disease. You think about somebody who's got COPD. They're going to have structural abnormalities in their lungs, right? Their sympathetic nervous system is going to be upregulated. And we've got techniques that we can utilize to balance that sympathetic nervous system and also increase their rib cage movement and their overall air movement in and out. So really anybody. Treating kids is great. If you can get kids, they start having some scoliosis. If you can start getting those kids treated early, you can prevent a lifetime of back pain. It's going to be something that's going to be maintained. But if we identify it early and start treating them, we can do some muscle retraining, a lot of times in conjunction with physical therapists and occupational therapists to try to make sure that we keep them functioning as good as possible. I know you'd mentioned, are there people that should avoid this? And pregnancy was one of those, but no, absolutely. Pregnant patients do really well with OMT because think about it. When is the body more kind of out of whack than when you're carrying a baby? And the pelvis has got to be optimized for childbirth. So I love treating pregnant patients, and they love getting osteopathic manipulative treatment during that time.
Now, when we're talking about these manipulations, what is it that you prepare people mentally that will happen, and how long? Are we talking about, it's like a 60-minute massage type
that
situation? Or are we talking about like a 2-minute quick something?
It is sometimes hard to describe to people. I'm like, sometimes you just have to experience it to really understand. And some people don't. They just call it their massage and we roll with it because it's not just massage.
Yeah.
But myofascial techniques and soft tissue techniques are certainly part of what I do. And when we call it that, I said, okay, it's a massage, but it's a massage with a purpose because I'm targeting a specific muscle group or a specific set of muscles. But essentially, I tell patients, I'm going to use my hands. I'm going to do a screen. We call it a screen. So we're just doing a head-to-toe assessment to see what is restricted within the body. And I'll do that with my hands. Certainly, we can incorporate imaging into what we do, but I don't rely on that to tell me where I need to focus. And then I'll talk them through that. I'll position them in different positions. We talk about it along the way. A lot of times you're going to be laying on a table, a flat, just exam table. I'll do some things sitting up. I've got a lot of experience treating elderly patients who it's hard for them to change positions a lot. And so we can adjust that as well. Pregnant patients too. You get so far along, it's hard to lay flat on your back. We can adjust how we do things. But for the most part, it's going to be about 60 minutes, ideally. When I was practicing in kind of an employed model, and they would give me 30 minutes and that was about it. And I would have liked to have had more. So now it is about 60 minutes. It really depends on what a person has going on.
Yeah, so that 60 minutes would be more for an overall thing as opposed to somebody coming in and saying my shoulder hurts or whatever.
Absolutely. If somebody comes in with an acute thing, shoulder pain, hip pain, we'll address that a little bit more focused. But again, knowing that the body is connected, that hip pain, a problem could be in their opposite shoulder. And this is a compensation. So we're looking at those things too. People are either used to massage therapists or they're used to chiropractors. And we're not unlike either of those, but we're not the same as either of those when we do manipulation. We learn the modality of what we call high velocity, low amplitude popping and cracking that you typically associate with chiropractic care. That's not my favorite way to treat things. I like to do more of an indirect approach. And again, focus on the ligaments that are connecting bones together, the muscles that are there as well. If we can loosen those restrictions, the skeletal aspect will align back without having to force it. And so it's not uncommon for us to treat somebody and then they sit up and they start moving and you have articulations in the spine. And they're like, oh, that popped. And it's like, yeah, because we gave it the ability to reset itself.
Another aspect of OMT that I think that some people aren't familiar with, but it can be greatly beneficial is headaches.
Oh, yeah, absolutely.
Can you explain that and how you can use that to help with a headache? Because I don't think people necessarily would be like musculoskeletal, oh, I should go there for my headache.
Mm-hmm. Again, we talk about the body and its connections. A lot of headaches are tension headaches and can even migraines are triggered by a tension headache. And so having the knowledge that all of these upper back and neck muscles actually attach to the base of the skull and can put strain there and decrease blood flow and increase sympathetic drive and decrease the parasympathetic. So it really messes with our nervous system. The other thing people don't realize is that our head is not one big fused together bone. There's lots of little bones in there, and there's very fine, minute movements in those bones. And underneath of that is a membrane that connects it together, and then all of the blood flow to and from the brain is right underneath of that. So there is an entire sect of osteopathic manipulation that's called cranial manipulation, and we optimize those cranial bones, those head bones, to improve spinal fluid movement, blood flow, lymphatic and glymphatic drainage, and then obviously reducing the tension and the input of shoulder and upper back muscles, neck muscles that are going up and affecting the head as well.
Sometimes people don't realize that those muscles from the upper back are going all the way attaching on your head.
Yes.
But I will tell you about something that shaped me, because I will never forget this. In residency, I saw a young man who had some sort of neck manipulation. I don't know who it was by or exactly what it was, but it had caused a vertebral artery dissection, and he had a major stroke that will impact him for the rest of his life. And so that made me very fearful of anyone. And I think a lot of doctors are this way. A lot of MD trained doctors are very fearful. I would always tell my patients, if I knew they were going to a chiropractor for their neck pain, I would just be like, don't let them snap your neck. I don't want that to happen. And I would just say, why don't you just do the lower back? But I don't know, do you have any thoughts about that? Or are there things people should definitely avoid? The neck has so many critical structures.
Right.
What would you tell people about that
So
safety-wise?
That is definitely something that happens. It has happened. And again, as osteopathic physicians, we did learn kind of the popping of the neck. You've got to make sure some people, when they manipulate the neck, do a lot of rotation, and that's where it can get very dangerous. Personally, I don't use those modalities in the neck. I think there are better modalities that get longer lasting effect. If you've ever had your neck popped, it's like, oh, that feels great. And then the next day it hurts again. And it's because we haven't addressed the tight muscles and the ligamentous tension that is being held between those two bones. So again, it's definitely a very real possibility for that to happen. It's very low likelihood, but it happens. I do not do that when I treat necks. And some people do it and they do it very effectively, but there's always a risk. The people that you typically want to think about not doing that type of manipulation on are people like rheumatoid arthritis. I would be hesitant to do it on any elderly person just because osteoporosis is very real. People with Down syndrome, they have issues at the atlantoaxial joint, and that is another place that you can have some issues there. When we talk about osteopathic manipulation, there are hard contraindications and there's some relative contraindications. And one of the things is just patient lack of comfort. And if somebody doesn't want that type of treatment, then that should be respected. And I've heard people going to different practitioners and they're scared to get their neck popped and they still get their neck popped. That's something that really shouldn't happen because that, again, they're going to tense up, number one, and make the treatment less effective, but patient autonomy and their ability to dictate their care.
And as someone who does hold stress in their neck and shoulders,
as most of us do, right?
If you were to manipulate me, and let's say you do that, and if you want to, you're welcome to. Let's say you do that, and I feel like, oh, wow, that feels really good. Now, what do I do to not feel that same stress and tension there tomorrow?
Again, everybody's a little bit different. A lot of times when I will identify something, we'll talk about ergonomics. And a lot of this is posture, especially with those shoulders and the upper back and neck. A lot of it is posture. Us looking down at electronics. We used to read a book, but now we're on our phones or iPads or something, and our head is always down. And we're putting tension on certain structures. So I will talk with patients, and a lot of this tension is coming from these shoulders. And here are some exercises that we can do to normalize this restriction. We got to take a break throughout the day. Head up, shoulders back, chest out, and really adjust how we're sitting. And I'll give them some specific stretches. If you look in the literature, and it's more so in the physical therapy literature than the osteopathic literature, but there's a thing called upper crossed syndrome and lower crossed syndrome. And it's really a postural imbalance of muscles. And if we could fix that, we would fix probably 80% of neck pain and low back pain by optimizing muscle strength in certain muscles and decreasing the tension in others. There's an imbalance there.
You all didn't see this, but both Kitty and Ash up super straight immediately. We're
super straight, right?
That'll last a good 10 seconds.
So I had a lot of patients that would see chiropractor, and they would go regularly, as opposed to, oh, I lifted a box I shouldn't, and now my elbow hurts. But with chronic stuff, would someone see you regularly for that?
So when I typically see someone the first time and we'll do a head-to-toe manipulation, number one, they're probably going to be sore the next day because what we've done is we've now woken up some muscles that really haven't been doing their job. So it's if you go to the gym and you haven't worked out in a while and you're really sore the next day. The other thing we've done is we've reintroduced blood flow to some areas that really didn't have great blood flow, opened up some of those pathways. So lactic acid has been trapped in areas, and that's going to come out and cause a little bit of discomfort. So I have people will often tell me like, oh, that next day I was really sore. But 3 days later, they're like, I feel great. Everything is much better. So what I always tell people is after a treatment, plenty of rest and water is the big thing. Drinking plenty of water for the next 24 to 48 hours to really flush the system. And then when I've seen somebody like that, really depending on what they've had going on, their history, how long have they been dealing with this pain? Again, this is very personalized on each individual person. I'll have them come back in about 2 weeks, I think is a good time to see We've adjusted the skeletal system, let them go out and live life with this new normal that we've created, and then we'll see what it gives it back to us, right? Are we seeing the same thing again? Then do we need to start looking at there's something we need to correct in the way you're sitting on the couch or the way you're sitting at your desk. Or I've people, they'll tuck a leg way up underneath of them and get all contorted. And this is the pattern that we're seeing. So we kind of do some retraining in that aspect. But I've had plenty of people who have chronic pains, right? Whether they have fibromyalgia, rheumatoid arthritis, or whether they just have some spinal stenosis and herniated discs in their back and they're not ready for surgery or surgery is not an option for them. We can tune them up a little bit, get things working a little bit better, and they'll come and see me about once a month. And that's a pretty good schedule for most people. I've had patients in the past. I had one gentleman in particular that getting OMT every 2 weeks kept him off of narcotic pain medications. And he would tell everybody, he knew that. This is my pain medicine. This keeps me functioning, keeps me off of pain medicine, because he'd been down that road before and had recognized that these pain medicines could get addicting really quickly. And so that was his option. I've had people with fibro. That's another group of patients that really do benefit because I'll do a lot of work on the fascia itself, which is where most of those pain points are coming up, is within the fascial layers of the body. And I had people that I would see regularly with fibro.
Now, if someone is working on a specific chronic joint issue with a physical therapist, is this something that they could pair with their physical therapy as they're trying to get stronger to help also with pain management as well as going through that process?
Absolutely.
Okay.
So these are some of the most common other disciplines that we would work with or that we do work with in OMT. There are physical therapists, pain management, interventional pain specialists. We had a lot of referrals from them.
We had one on our show last week.
Yes.
That's right. Go back and listen to that one if you haven't.
Absolutely. OBGYNs are the others, the pain related with pregnancy, and neurologists, because they recognize that head, neck, upper back connection with headaches and migraines. Those are some of our highest utilizers as referral sources.
Yeah. And Sarah's still sitting really straight. I've already started slouching again, but she's still speaking of the head and neck thing there.
Yeah. But physical therapy is great. They've got a lot of tools where they can actually measure, are we strengthening the right muscles? Are we stretching the right muscles? And they can give you dedicated time to focusing on those. And I can give them, we really need to stretch this piriformis muscle, or we really need to work on these trapezius muscles. And they can spend that time. And then they've got, a lot of them have diagnostic tools where they can see, are we firing the right muscle that if we're trying to strengthen something? And so that's definitely helpful.
I get really giddy when I see these beautiful interprofessional teams that can come together and truly help people heal, because I feel like many times in traditional medicine, everyone's working in their own silo. But I love hearing, hey, if we bring this person and this person to the table, we can create a plan that can truly heal someone. It's just beautiful to me.
It is. Yeah. Thinking about that too, we mentioned stress often causes a lot of these problems with neck and headache and things. Are there things you typically recommend for stress reduction outside of that when you're trying to get someone to maintain the manipulation and things?
It's really personalized. I do spend time trying to get at what's going on. What's going on in life? Is this a problem with family members at home? Is this a problem at work? And trying to address the mental health aspect of a lot of this. I end up being a therapist a lot of times during these manipulation sessions, which is fine because sometimes you get people to start talking about this and you can feel the tension just going away almost instantly because they've been bottling some of these things up. If there's changes they can make or some encouragement that can be had, then certainly we talk about that. Sometimes people are just stuck in situations and you try to help them cope through some of this. As far as actual treatment to do at home, I'm a big fan of if people are able to do meditation and mindfulness, journaling if it's kind of anxiety and worry. I'm a big fan of if you've got a tub, get Epsom salt bath and just, number one, you're away, you're by yourself, you're relaxing, but also magnesium is really well absorbed through the skin. And so Most of us are deficient in magnesium, and we store that in our muscles and our bones. So it's a good way to get magnesium into the system, and it helps a lot with some of these muscular aches and pains. I'll tell people if they don't have a tub or they don't feel like they have the time, topical magnesium oil or cream, I'm a big fan of using those as well.
So magnesium is helpful. Are there any other nutritional recommendations that you recommend for people where OMT is helping their pains?
As you guys know, this is your space, the lifestyle medicine. So much of our food is inflammatory. So much of our food is inflammatory. And a lot of that drives some of this continued inflammation in the body. So trying to encourage some of those healthy diet choices and lowering some of that inflammatory food can really go a long way. I have people who've gone on keto diets or low-carb journeys. They will tell you how much improved their back pain is with doing nothing but changing their diet. And so I think trying to do that, but it's easier said than done for a lot of people, especially the way we live our lives now. We're always on the go and busy into the next thing. But if we can incorporate some more of those fresh, healthy foods and get some of the processed fast foods and quick foods out of our diet, it will lower the inflammation big time.
And then another big pillar of lifestyle medicine is sleep.
100%.
I was like, we can't leave this in talking about trying to manage some chronic pain without also addressing sleep's impact. What is your experience with trying to focus on sleep and the improvement in general in people's musculoskeletal system, as well as handling the stress and tension that builds up?
Sleep is when our body gets its restoration, right? Sleep is super important. Sometimes weird people out when I can usually tell them what side they sleep on based on their dysfunction in their shoulders. And they're like, should I not? And I said, no, I want you to keep sleeping however you get the best sleep, because sleep is more important. I don't want you worrying about different positions. You definitely need to get the sleep that you need. Obviously, I think there's a lot of undiagnosed sleep apnea out there as well, which is going to affect all of our health and will also affect the structure as well. So I think making sure that people, if I'm seeing them, if they're my own primary care patient and we're doing manipulation, making sure that we have addressed all of those aspects that can affect sleep. And if they're not, if they just come to me for OMT, having them have that conversation with their physician.
So now that we've talked about what OMT is in your practice, so you have a direct primary care practice to get all your traditional primary care needs met, and then you also do manipulations. Is that something that only people in your direct primary care practice can receive, or do you have the option to just come see you for manipulation? How does that work?
And that's a good question. And that was something that it was honestly a pain point when I was setting up my practice to how to do this. Because not everybody needs primary care from me and not everybody needs manipulation from me. So I did keep the two separate. So I've got the primary care membership. And if my members want to get OMT treatment, and again, it's the full head to toe, we're doing it all, then that isn't an additional cost. And it's $49 on treatment. If people have their primary care physician, they're happy with it, but they want osteopathic manipulation, then I do have a means for them to come in and we'll do an initial consultation, which that probably takes more than an hour, usually about 90 minutes, because it's important for me to get your medical history, know what all's been going on, what's been done. If you've had, do you have herniated discs in your back? Do you have herniated discs in your neck? Kind of what treatments have you undergone? That takes about an hour and a half, and that consultation is $189. Follow-up treatments after that are $139. So obviously, if you're somebody who needs primary care and wants manipulation, I priced it to where membership is beneficial for you, especially if you want to get manipulation every couple of weeks, which some people do. Right now, not a lot of people in Lexington know what OMT is. Certainly when I worked in Eastern Kentucky, it's still in very high demand over there. So it's only a matter of time here in Lexington. Now, for members, it's not to say that if someone comes in with a very specific, I strained my knee yesterday playing soccer, that I'm not going to do some manipulation on that, kind of quick and focused for it. That's going to be included in membership. But when we come in for kind of that, I'm coming here for an hour, I want you to do a head-to-toe assessment, then there is that additional fee on top of membership.
Just so our listeners know, how far out do you book for non-members to get that done? Are you able to get people in within a week or two?
Within a week right now, yeah.
Because that's usually the issue.
That's
You're
the
like,
big
I need
thing.
somebody now,
Right,
but
yeah.
I can't see someone for 3 months.
Yeah, when I was working in the employed system, it was an 8-week wait for an appointment for OMT. It was an 8-week wait.
Long time to wait.
It is a long time to wait.
We will link to you in the show notes. Any other way, just how can people find you?
Yeah, I'm on Instagram and on Facebook at Body, Mind, Spirit DPC, and the website has plenty of information there. Feel free to give me a call, and I've had plenty of people who just have questions about what is this like, and we'll set up a meet and greet and let you come in and see the clinic and ask questions and see if it's a good fit for you too.
Oh, that's great. And are there any other resources out there that you think are reliable if someone's just wanting to look more into both DPC as well as OMT? Are there any reliable sites or?
There are certainly lists of DOs out there, but finding a DO that does manipulation is sometimes difficult. Right now, I don't think there's a great list. I work with the State Osteopathic Association, and that is one of our goals for this next year, is to get a list that's out there for the public to see people who do osteopathic manipulation. Right now, obviously, if you're on the other side of the state or somewhere else, and you can send me an email or send me a message on social media, I would be glad to find you somebody near you, because we are a small community and very interconnected, so we can usually find someone nearby in other states.
Oh, that's great. We have learned so much today. You have taught us about direct primary care and what that offers, which is really just a ability to have more of your attention and to not feel as rushed and to really have a better patient-physician relationship and do that at affordable prices, including things like labs and medications and other things that you may not have thought that would be the cheapest option, but it very well may be, depending on your insurance, the cheapest option for you and a great option for care. And then keeping in mind that OMT can really treat a lot of different conditions. I had never thought about it for things like COPD and being able to help expand the rib cage for breathing. So that's really neat how you can connect that to those chronic conditions, in addition to, of course, feeling pain and tension in your body. So if that's something that you feel like would be beneficial to you, it is definitely worth looking into finding a DO that practices OMT near you. Hopefully this has been helpful for you to know, and I think that we're only going to be seeing more DPCs coming up in the future.
I just want to also emphasize here, even though I do not personally have a direct primary care practice myself, I believe in this model. I love this model. I think it's a great way for people to receive primary care. So I want to commend you on having this practice. Many times I have patients looking for this exact thing. So we were so excited to have you on our show so someone can understand a little bit more how this model works. Many people need this in their care so they can get high quality primary care. Next week, though, we are going to continue on this journey of the musculoskeletal system, but it's going to be a little bit different because we're going to have a rheumatologist. Her name is Dr. Pinkston, and she is board certified in internal medicine and integrative medicine as well as rheumatology. And she is extremely excited to talk about inflammation and musculoskeletal pain in this scenario, and how lifestyle medicine can impact your overall care. And I don't think there's many practitioners here in Kentucky that has this focus that she specifically has.
Yeah, so we're really looking forward to all of the information that she is going to impart on us. And let us know, again, if you have any questions, go ahead and click on that Send Us a Text button there, and you can let us know what's on your mind or send us an email at contact@thestartinggatepodcast.com. We'll see you next week.
Bye.